Good morning, everyone. Today we will be discussing regarding T lymphoblastic leukemias and T lymphoblastic lymphomas. This is a basic outline of my presentation. We will be discussing regarding the biology of T cells, clinical features, diagnosis, risk stratification, and treatment of adult T cell leukemias. Coming to the biology, this is the diagram showing normal hematopoiesis. Hematopoietic stem cell present in the bone marrow gives rise to lymphoid progenitor and myeloid progenitor. The lymphoid progenitor in the bone marrow gives rise to B lymphocytes and T lymphocytes. The origin and development of B lymphocytes occur in bone marrow. In contrast, the T lymphocytes originate in the bone marrow. However, the development and acquisition of function of T cells occur in thymus. Understanding the origin of T cell leukemias require basic understanding of the T cell development. The hematopoietic stem cells present in the bone marrow gives rise to progenitor cells called common lymphoid progenitor. Progenitor cells are the cells which are primed to become T cells. These common lymphoid progenitor cells present in the bone marrow travel through blood to reach thymus. The earliest cells which enter into the thymus are called thymocytes. Once they reach the thymus, the subsequent development and acquisition of function of T cells occur in thymus. This process of maturation is reflected by changes in immunophenotype, as in which the cells acquire different expression of antigen as they move from cortex to medulla. So the initial cells which enter from the bone marrow into the thymus are called double negative thymocytes. Double negative, they mean they lack the expression of CD4 and CD8, and they even lack the expression of T cell receptors. The double negative uh, T cells present in the thymus in the subcapsular region move from the subcapsular region to the cortex. The initial cells in the cortex are called early cortical cells. These cells acquire the expression of CD1A, and once they move from early cortex to the deeper part of cortex, they acquire the expression of CD4 and CD8. These cells are called double positive T cells, and these cells move from the cortex to the medulla. They interact with major histocompatibility complexes, and they become either single positive T cells, that is, they express either CD4 or CD8. These mature medullary thymocytes from thymus enter the blood and reach the lymphoid organs. Uh, After knowing that basic T cell development, uh, the T cell leukemias occur from the cells which are present in the thymus, whereas from the peripheral T cells, these cells gives rise to peripheral T cell lymphomas, adult T cell leukemias and lymphomas, which are completely distinct entity from T cell acute lymphoblastic leukemias. Coming to the in the recent 2016 WHO classification, T cell lymphoblastic leukemias and lymphomas are entitled under precursor lymphoid neoplasms. And in the recent classification, there is a subtype of T cell lymphoblastic leukemias and lymphomas called early T cell precursor, which is recognized as a provisional entity with inferior outcomes compared to T lymphoblastic leukemias and lymphomas. Coming to the immunophenotypic classification of T cell acute lymphoblastic leukemias, uh, the earliest cells which enter the thymus from the bone marrow, these are double negative T cells. Uh, these double negative T cells comes under pro T cells and precursor T cells. As we have seen initially, these cells lack the expression of CD1A because these are present in the subcapsular region, and the cortical T cells has the presence of CD1A and expression of CD4 and CD8. These are the double positive T cells, whereas the pro and pre T cells are double negative T cells and lack the expression of CD1A. And the mature T cells lack the expression of CD1A and have either expression of CD4 or CD8. what is the value of this immunophenotypic in T cell acute lymphoblastic leukemia? This is the study done in CalGB group, where they evaluated the prognosis based on the immunophenotypic classification. The patients who had pre and pro T cells have inferior outcomes compared to mature T cells. So this suggests that there is a distinct subtype of T cells which had poor outcomes compared to T cell acute lymphoblastic leukemias. And this is the other study done in adult T cell acute lymphoblastic leukemias, where the presence of pro and pre-T cells are compared with cortical and mature T cells. We can see that the response rates of cortical and mature T lymphoblastic leukemias had better outcomes than pre and pro T cell acute lymphoblastic leukemias. Coming to the gene expression signatures, based on gene expression profile, they identified genes which are control T cell differentiation, apoptosis, and T cell proliferation. Based on this, they had identified 3 distinct molecular subtypes of T cell acute lymphoblastic leukemias. The cells which are arising from the double negative T cells had then arrested double negative T cells. These comes under LYL arrest, and these cells, as we have seen in the immunophenotypic, they lack the expression of CD8 and CD4, and they had the expression of CD34, which is an stem cell marker. And the other subtype which has identified based on gene expression signatures is HOX11 arrest. This HOX11 is also called TLX1 and TLX3. These are the early cortical T cells where they had an expression of CD1, CD8, and CD4. And the other subtype was Tall type of T cell acute lymphoblastic leukemias. These cells arise from the late cortical T cells, and they had their expression of CD4 and CD8 and high levels of surface expression of CD3. So based on this understanding of basic T cell development, the T cell acute lymphoblastic leukemias arise from the cortical and medullary thymocytes, whereas there is an early precursor type of T cell acute lymphoblastic leukemia. These arise from the cells which are just migrated from bone marrow to the thymus. These cells are not committed completely to become T cell lineage, and they retain the capacity to differentiate into dendritic, myeloid, and stem cell progenitor cells. Coming to the correlation between molecular and immunophenotypic subtype, as we had already seen, pro and pre T cells as the immunophenotypic of early T cell precursor ALL, they lack the expression of CD1A, CD4, and CD8. Based this immunophenotypic type of pro and pre correlates with the ETP-ALL type, and the cortical types which had the expression of CD1A correlates with the TLX or HOX11 subtype of T cell acute lymphoblastic leukemia, and the mature medullary T cells where where acute lymphoblastic leukemia arises from the mature T cells corresponding to Tall type of acute lymphoblastic leukemias. Coming to the epidemiology and clinical features of T cell disorders, lymphoblastic disorders are classified as lymphoblastic leukemias and lymphoblastic lymphomas based on the bone marrow blast. The patient has less than 20% bone marrow blast and predominantly extramedullary involvement. We call it as lymphoblastic lymphomas. Whereas the patient has bone marrow blasts of more than 20%, we call it as acute lymphoblastic leukemias. Out of acute lymphoblastic leukemias, T cell acute lymphoblastic leukemia comprises of 15% of leukemias in children and 25% in adult. In contrast, the majority of lymphoblastic lymphomas are T lymphoblastic lymphomas. 85% of the lymphoblastic lymphomas are TLBL, and they usually present with mediastinal mass, and other sites of presentation is lymphadenopathy and hepatosplenomegaly. And CNS involvement in lymphoblastic lymphomas are rare. They had less than 3% involvement of central nervous system at presentation. Coming to the clinical features of T cell leukemias, uh, we can see the differentiating features between T acute lymphoblastic leukemias, ETPALL, and T lymphoblastic lymphomas. Uh, all these subgroups has male predominance, and T lymphoblastic leukemias present with high white cell count. In contrast, ETPLL has low white cell count and low blast percentage, and TLBL predominantly present with mediastinal mass, and bone marrow involvement is usually less than 20% blast, and all present with hepatosplenomegaly and lymphadenopathy. Apart from this, lymphoblastic lymphomas can have presence of pleural and pericardial effusions, and TALL and ETPLL has similar incidence of CNS involvement, approximately 9%. In contrast, T lymphoblastic lymphomas has low incidence of CNS involvement at presentation. Coming to the diagnosis of T cell acute lymphoblastic leukemias, this is a basic workup we do for acute leukemias. Complete blood counts, manual differential counts, TLS parameters, and viral markers. And for establishing the diagnosis, bone marrow cytomorphology, immunophenotype, cytogenetics, and bone marrow biopsy, and CSF analysis by morphology and flow cytometry at baseline, PET-CT in case of T lymphoblastic lymphomas, and if the patient present with T lymphoblastic lymphomas, biopsy from the accessible lymph node site or mediastinal mass is required for definitive diagnosis. Coming to the morphology of lymphoblastic leukemias, these blasts are small to medium in size with scanty cytoplasm, and predominantly had condensed to dispersed chromatin and prominent nucleolus. In case of T lymphoblastic lymphomas, blasts have similar morphology. There is effacement of lymph node architecture and involvement of the capsule. Coming to the immunophenotype, there are different markers which helps in diagnosing T lymphoblastic leukemias. One are the markers of immaturity. The CD34 and TDT are the markers of immaturity. And lineage specific marker, cytoplasmic CD3 is in T cell lineage specific marker. And the lineage associated markers, which include CD1A, 2, 5, 7, and CD4 and CD8. Coming to the diagnosis of T acute lymphoblastic leukemias, these cells should have the cytoplasmic CD3 positivity, and along with cytoplasmic CD3 positivity, they can have the variable expression of CD1A, CD5, CD8, CD4. Coming to the diagnostic criteria for ETPALL, so as we had already seen that ETPALL arises from the cells which have just entered the thymus, and they arise from the double negative T cells. They lack the expression of CD8, and these as these cells arises from the precursor double negative T cells, they lack the expression of CD1A, which is present in cortical T cells, and along with it, they should have one of the stem cell or myeloid antigens. As we already seen, these cells can differentiate into either myeloid or stem cells. So to diagnose this as ETPALL, all patients must have the cytoplasmic CD3, which is the lineage specific marker, and CD7 positive. Along with it, they should be CD1A negative, CD8 negative, and surface cytoplasmic CD3 negative. And these cells doesn't have any T cell receptors on the surface, so they should be T cell receptor alpha, beta, or gamma delta negative. The expression of CD5 should be negative or dim. Dim, I mean less than 75% of the blood should be positive. And one of the stem cell or myeloid antigen should be positive, like CD34, 13, 33, CD117. And coming to the genetics of T acute lymphoblastic leukemias, the mechanism underlying the development of T acute lymphoblastic leukemias include loss of transcriptional factors like WT1 and RUNX1, irregularities in tumor suppressor genes like cyclin dependent kinase 2 deletions, gain of function in oncogenes like increased c-MYC proliferation, and chromosomal rearrangements like NUP and ABL1 translocations. Coming to the basic understanding of the pathogenesis of T acute lymphoblastic leukemias, the Notch receptor is an important in development of normal development of T cells. Once the Notch receptor is activated by Notch ligand, the intracellular portion of Notch receptor releases into cytoplasm and binds to the target genes. Upon binding to the target genes, not target genes helps in T cell lineage commitment, T cell proliferation, and survival. The other important gene is Fbx W7 gene. This is the gene which, through proteasomal degradation, inactivates the activated notch. So, for the patients who have activating mutations in the notch and the mutations in WBX W7 that impairs the degradation of activated notch, both these results in uncontrolled notch signaling and increased T cell proliferation and survival and development of T acute lymphoblastic leukemias. The other genetic pathway is cell cycle dysregulation. Cycle independent kinases are important cell cycle regulators. The patient has inactivating mutations in cycle independent kinase. This The normal function of cycle independent kinases is, in case of any cell stressors, this causes the cell cycle to arrest at G1 and S phase, and through MDM and P53, it causes the apoptosis of the defective cells. When there is inactivating mutations in cycle independent kinases, this process is inhibited and cells can have uncontrolled proliferation through increased function at G1 and S phase. And majority, 60% of T cell acute lymphoblastic leukemias has Notch1 activating mutations, and 80% of them has deletions in cycle independent kinase gene. So both this leads to increased proliferation and decreased apoptosis, resulting in development of T cell acute lymphoblastic leukemias. And other genetic pathway of acute lymphoblastic leukemias is TLX-induced TALL. Translocation 1011 results in increased expression of TLX1 in progenitor T cells. Increased expression of TLX1 causes transcriptional repression of TLX1 target genes. This results in secondary mutations like activating mutations in Notch, inactivating mutations in cycle independent kinase, aneuploidy, and T cell differentiation defects. All this leads to increased T cell transformation and T cell acute lymphoblastic leukemias. So this is the thing already we have seen previously. So based on this, we can say that ETPLL arises from the double negative T cells, and TLX1 and TLX3 are the subtype of TLL arise from early cortical cells, and TAL type of TLL arise from the late cortical cells. And Notch signaling is important for differentiation from early double negative T cells to early cortical T cells. So for the patients, for the T cell ALL which arises from the double negative T cells, they have decreased frequency of Notch and Fbx W7 mutations, and along with they had a decreased frequency of deletions in cycle independent kinases gene. And as the TLL arises from the cortical and early and late cortical T cells, there is an increased frequency of Notch and WBX W7 mutations and increased frequency of deletions in cycle independent kinase 2. As we have seen the genetic basis of T acute lymphoblastic leukemias, let's see the genetic basis of early T cell precursor ALL. The genetics of ETPALL is different from the adult TALLs. As seen here, this is an exon sequencing done in adult ETPALL and compared with TALL. In contrast to TALL, ETPALL has increased frequency of DNMT3A mutations and FLT3 mutations. These mutations are common in myeloid malignancies, which suggests that this the cell origin the ATPll originates from double negative T cells, and these cells and propensity to differentiate into both myeloid and T cell differentiation. Coming to the risk stratification, as we have seen the genetics, based on genetics, we have divided T cell acute lymphoblastic leukemia into TALL and ETPALL. And we have seen the importance of WBX7 and Notch mutations in development of TALL. Based on genetic risk stratification, we can divide into T and ETPALL, because ETPALL has inferior outcomes compared with TALL. As we can see in the study, the outcomes with TALL are 84% compared to overall survival in ETPALL is only 19%. Other important marker is presence of Notch1 and WX7 mutations. Patients who had wild type Notch and WBX W7 has inferior outcomes compared to Notch1 and WBX7 mutations. Indicating this presence of these mutations indicate that the TLL is arising from the cortical T cells. Indirectly, the wild type presence of wild type Notch and FBX7 indicates this arises from the ETPAL. And the patients who had mutations in Notch and WX7, one study has evaluated the presence of concurrent PTEN and RAS mutations. The patients who had concurrent and PTEN and RAS mutations had inferior outcomes compared with without PTEN and RAS mutations. Other risk stratifier is response to therapy. For the patients who had persistent MRD after phase 2 of inductions has inferior outcomes compared with MRD of less than 0.01% at the end of phase 2. So we classify this TALL as per genetics and based on response to therapy. Coming to treatments, overall, compared to the historical TALS that this treated before 2000, there is improvement in survivals of TALL over the years. As we can see, the survivals in the recent era in TLL 5-year overall survival is approximately 80 to 90%, compared with historical TLL, which has survivals of approximately 20 to 30%. So these survivals has improved because of the use of pediatric protocols. These are the pediatric protocols which has been used, one BFM protocols used in 2000 to 2006, and Dana-Farber regimen which has used between 2005 to 2010, and others are UKLL and Children's Oncology Group protocols. These are the pediatric protocols which shown the better event-free survival and overall survival ranging approximately from 80 to 90%. And similarly, in adults, young adults with acute lymphoblastic leukemias, use of pediatric inspired protocols has changed the outcomes of young adults with ALL. As we can see, compared with historical CalGB trial, which has overall survival of only 40%, use of pediatric inspired protocols resulted in improved overall survival ranging from 67 to 70% in adults with ALL. So coming to the basic treatment schema, the pediatric inspired protocols comprises of an induction phase and a consolidation phase, and M phase, delayed intensification and maintenance phase. These are the drugs we used in induction phase. In phase 1, we use steroids, vincristine, daunorubicin, and L-asparginase. Previous studies have shown, compared with three-drug regimen, addition of daunorubicin has improved outcomes in acute lymphoblastic leukemias. And the goal of this induction therapy is to induce rapid remissions and restore normal hematopoiesis, and so that we can progress with further therapy. And after induction phase, we give in second phase of induction, which comprises of cyclophosphamide and cytarabine, along with 6-MP. Coming to the basic differences in the induction protocols, Several trials has done compared the steroids in acute lymphoblastic leukemias. They compared Dexa with prednisolone. Even dexamethasone had shown a superior event-free survival compared to prednisolone, and this superior event-free survival is because of the decreased incidence of CNS relapse with dexamethasone. In contrast, use of dexamethasone has resulted in high frequency of reversible myopathy and hyperglycemia, and dexamethasone has resulted in high rates of infectious complications and treatment-related mortality, particularly in adults. And the UK MRC trial has shown similar results, with dexamethasone having more favorable outcomes in both standard and high-risk ALL, and dexamethasone has shown decreased CNS relapses. However, using dexamethasone in adults results in high rates of complications and treatment-related mortality. So in adults, we use prednisolone in spite of improved results in DEXA because of the complications. And other things which are tried in induction is augmentation of treatment protocols. This is then augmented BFM protocol done in children with ALL. This in these patients who are more than 10 years of age and less than 10 with white cell count of more than 50,000 received induction with 4-drug regimen, and the patient who had M3 bone marrow at day 7 continued with similar induction, and at the end of induction the patient has CR as randomized into standard BFM and augmented BFM. Patients in the augmented arm received more doses of vincristine, more doses of L-asparginase, and more doses of cyclophosphamide. Patient uh, in this trial, majority of the patients has B cell lineage. Only small percentage, as seen here, as T cell lineage acute lymphoblastic leukemias. In these patients, patient who had used augmented BFM has better outcomes compared with standard BFM. And this augmented BFM fare better in T lineage acute lymphoblastic leukemias compared with B lineage acute lymphoblastic leukemias. However, this augmented BFM protocol has resulted in increased toxicities and increased treatment-related mortality. And these are the trials in adult acute lymphoblastic leukemias. Uh, these these trials used adult protocols. Uh, this is the hyper-CVAD protocol used in T cell lymphoblastic leukemia and lymphoma. We can see the outcomes of TLL with adult protocols using hyper-CVAD as inferior, with overall survival of only 35% at 2 years, compared with the overall survival of 80 to 90% with the pediatric protocols. And this is a similar protocol used in Swedish adult acute lymphoblastic leukemia group, where the patients who had used treated with hyper-CVAD had inferior outcomes, and the age less than 35 has better outcomes compared with age more than 35. So what this suggests is this regimen doesn't have L-asparginase, which is an important component of pediatric protocols. Uh, so let's see the importance of L-asparginase in T-cell acute lymphoblastic leukemias. This is a study done in pediatric oncology group. These patients who patients who had attained CR as received weekly 12 doses, 20 doses of L-asparginase, and for the patients who received L-asparginase compared with patients who didn't receive L-asparginase, there is improved event-free survival for the patients who received L-asparginase. And in adult protocols, this is the study done by CalGB group. Patients who had effective depletion of L-asparginase with the use of L-asparginase compared with who doesn't have effective depletion. Patient who had effective depletion has better outcomes compared with who didn't receive L-asparginase, and these outcomes are better in T lineage acute lymphoblastic leukemias compared with B lineage acute lymphoblastic leukemias. And this is the similar outcomes shown in GMAL study, where patients are received pediatric inspired regimens containing L-asparagines. In these patients has an improved overall survival with 3-year overall survival ranging from 75% in T-cell acute lymphoblastic leukemias. This suggests that L-asparagine is an important component in T acute lymphoblastic leukemias, which has shown better outcomes with overall survival of 75% compared with hyper-CVAD protocol, who had an 2-year overall survival of only 35%. Coming to the CNS directed therapy, the incidence of CNS involvement at presentation in T acute lymphoblastic leukemias is high compared with BALL. TALL has an CNS involvement at presentation of approximately 10% compared with 4% in BALL. And the patient who had CNS involvement at presentation has inferior overall survival, 42% compared with 29%. And uh, in uh, children with T-cell acute lymphoblastic leukemia, pediatric oncology group has studied the effectiveness of high-dose methotrexate, where use of high-dose methotrexate has been compared with patient who didn't receive high-dose methotrexate. Patient who received high-dose methotrexate has improved event-free survival compared with patients who didn't receive high-dose methotrexate. And they postulated that this improvement in event-free survival can be either because of decrease in CNS relapse, or some say this improvement is because of the better systemic control. And in adults with TLL, there is a limited data about high-dose methotrexate. However, we as adopted from pediatric protocols, and we use high-dose methotrexate with intrathecal methotrexate as a part of CNS directed therapy in TLL. Uh, there is doses usually range from 1 to 5 gram per square meter. We usually use 3 gram per square meter as a part of CNS directed therapy. And this is the similar study where the patient who received high dose methotrexate has decreased incidence of relapses compared with who doesn't receive high dose methotrexate. And other part of CNS directed therapy is comparing Capezi methotrexate versus high dose methotrexate. Capezi methotrexate, I mean usage of methotrexate of 100 milligram per square meter on day 1, and if the patient has tolerated well without any toxicities, the dose of methotrexate has increased by 50 milligram per square meter at each subsequent dose. And this has been compared with high dose methotrexate, where dosage was 5 gram per square meter given every 2 weekly for 4 doses. Uh, uh, Use of high dose methotrexate was associated with better event-free survival, and in patients who had high MRD negativity at induction, and compared with Capezi methotrexate. The event-free survival was 68% with high-dose methotrexate compared with Capezi methotrexate, which had event-free survival of 58%. And similarly, this is the comparison between Capezi methotrexate and high-dose methotrexate done in children, where the patient they are compared Capezi with high-dose methotrexate with or without nelarabine. So what this trial suggested was in children, Capezi methotrexate with the nelarabine improved survival both in terms of event-free survival and overall survival compared with high-dose methotrexate. However, this trial contains only 3% of the patients in these trials had adult patients, and the important caveats of the trial was administration of cranial irradiation. Patient who received Capezi methotrexate received cranial radiation at earlier time point compared with high-dose methotrexate patients, where they received cranial radiation 4 months after completion of treatment. And patient who received Capezi methotrexate received 2 additional doses of asparaginase. So, suggesting these components might have resulted in superior outcome with Capezi methotrexate compared with high dose methotrexate. coming to the outcomes in adolescent and young adults, as we have seen from previous treatment protocols, patients who pediatric protocols has better overall survival ranging from 60 to 80% compared with adult protocols who has received hypercVAD without L asparaginase. They had an oral survival of 35%. And even though these outcomes are better than adult protocols, still the outcomes are inferior to children. So for the patients who had adolescent and young adults, uh, we use pediatric inspired protocols because of the better outcomes compared with adult protocols. Coming to the outcomes in older adults, uh, patients who has treated in older adults has similar complete response rate as in BALL. However, the complete responses decline with increasing age, and there is association between gender presenting white cell count and immunophenotype. This is a Gemema large study where older patients who had treated with multi-agent chemotherapy. For the patient who had more than 30 years of age has less CR rates, and females has less CR rates. And other thing is presence of high WBC counts resulted in low CR rates. And if the patients had a stem cell marker like CD13 and 33 and myeloid markers, they had an less CR rates compared with absence of myeloid and stem cell markers. And patients who had increased expression of MDR has less CR rates compared with without expression of MDR. So coming to the outcomes in older adults, the 5-year overall survival for older adults treated with multi-agent chemotherapy has 48%. And these poor outcomes in the subgroup analysis, these poor outcomes are persisted in patients with white cell counts of more than 1 lakh and who had absence of CD1A and presence of stem cell and myeloid markers and poor outcomes. And patients who had complex karyotype, which I mean more than 5 chromosomal abnormalities, and presence of 17p deletion has poor outcomes. And the relapse rates in older adults is 37% at 1 year. This is an UKLL study in older adults, where we can see that the presence of complex karyotype and 17p deletion has 5-year overall survival of 20%, and other genetic parameters has overall survival ranging from 30 to 40%. Coming to the role of nelarabine in newly diagnosed T-cell acute lymphoblastic leukemias. Nelarabine is a purine analog which gets incorporated into T cells and causes the destruction of T cells. This is then study done in UKLL study where the patients has received standard induction, and after patient who has undergone into remission as randomized to nelarabine and without nelarabine. As we have seen, there is no difference in outcomes in patients who received nelarabine with and who didn't receive nelarabine. The event-free survivals and overall survival are similar between the two groups. And this UKLL 14 study has identified some markers which has predicted inferior outcomes. As we have seen, the early T cell precursor arises from the double negative T cells, and these cells lack the expression of T cell receptor. They had identified then absence of biallelic deletion, which identifies the absence of T cell receptors on the surface of T cells. And these cells had increased expression of uh, SAM-HD. They had suggested that increased expression of SAM-HD has resulted in resisted with nelarabine. And this is the UKLL study where patients received phase 1, phase 2 induction similar to pediatric inspired protocols. And if the patient has entered into remission, they're randomized to nelarabine and with and without nelarabine. And the patient who there is no difference in outcome between the two groups. And uh, patients who had absence of ABD, which reflects the ETPLL group, as high rates of MRD positivity compared with absence of T cell receptor gene on surface. This is the Kaplan-Meier showing the risk of relapse with ABD status. Patient who has ETP-ALL reflected by absence of ABD allele has high incidence of CNS relapse compared with other subgroup. And these are the other study which was done in MD Anderson. Patient has received adult protocols hyperCVAD with or without nelarabine. Compared with historic hyperCVAD data, addition of nelarabine doesn't provide any survival benefit in adult T acute lymphoblastic leukemias. So to conclude that nelarabine doesn't have any role in newly diagnosed T cell acute lymphoblastic leukemias. Coming to the treatment of early T cell precursor acute lymphoblastic leukemia, this is a subgroup of TALH which has inferior outcomes. These are the two studies. One, the topmost study is the CalGB study, and bottom is the BFM study, which said ETP-ALL has inferior event-free survival, overall survival, and increased incidence of relapse compared with T acute lymphoblastic leukemias in children. And this is the other study done in Tokyo Children's Cancer Study, where patients with early T cell precursor acute lymphoblastic leukemia has inferior event-free survival compared with T acute lymphoblastic leukemias. Coming to the adult patients, patients similar to the pediatric patients, adult patients also has similar outcomes. Patients with ETP-ALL has inferior outcomes compared with non-ETP-ALL. So what is the important clinical factors in ETP-ALL is this is the BFM study where it showed majority of the patients of ETP-ALL has poor prednisolone responders compared with TALL. We can see that 50 to 60% of the patients with ETP-ALL are poor response to prednisolone, and day 33 MRD also has a majority of ETP-ALL has persistence of MRD at day 33. As we can see, less than 5 into 10 power minus 4, only 14% of the patients of ETP-ALL in BFM 2006 study and BFM 2009 study, only 8% has MRD negativity. However, the patients has increased MRD clearance after phase 2 of induction. As one can see that 57% of the patients attained MRD negativity at the end of phase 2. This is the similar study, other study in adults with ETP-ALL showing similar results. Majority of the patients as ETP-ALL has corticosteroid resistance. The 60% of the patients has poor prednisolone response, and majority of the patients has chemotherapy resistance, which is lack of CR at the end of induction. And we can see that at the end of induction, majority of the patients has persistent MRD positivity. However, the percentage of the patients who had attained MRD positivity at the end of phase 2 is better. So what this study suggests is early T cell precursor TALL has poor prednisolone response, high rates of failure to achieve morphological complete remission, and high MRD positivity post induction. However, they had a better clearance of disease after phase 2 of induction. So what has changed in the treatment of ETP-ALL? One is intensification based on prednisolone response and post-induction MRD negativity, and use of allogeneic stem cell transplant in this high-risk subgroup. So this is then BFM study where patients who are poor prednisolone response, absence of complete remission at the end of induction, and persistent MRD positivity after phase 2 received intensified chemotherapy in the form of high-risk blocks. Uh, Other patients who are standard risk received regular conventional chemotherapy, and patients are allowed for allogeneic stem cell transplant if the patient has absence of complete remission at the end of induction, persistent MRD positivity at the week 12, and poor prednisolone response patients. And the other study has used in intensified chemotherapy in ETP-ALL patients who had bone marrow blast of more than 10% at day 15, and patient who had poor prednisolone received augmented therapy with cyclophosphamide at day 10. And in BFM 2009, they used PEG asparaginase in place of native asparaginase. What the study has suggested that patients who continued with phase 2 of induction, in spite of high rates of lack of complete remission, poor prednisolone response, had better outcomes with 4-year, 3-year event-free survival and overall survival of 86%. This is study done in children. So what this suggests is early T-cell precursor leukemias who was treated with subsequent phase 2 of induction with cyclophosphamide, conventional doses of cytarabine and cismecaptopurine is effective in decreasing the minimal residual disease. And this suggests that only less than 10% of the patients in this study has gone into stem cell transplantation. So this suggests in children with ETP-ALL who had MRD negativity at the end of induction phase 2, continuing with conventional chemotherapy without transplant has in similar outcomes with event-free survival and overall survival of 86%. This is a similar study done in children and young adults with ETP-ALL. These patients has a similar results with event-free survival and overall survival of approximately 70 to 80%. This suggests that ETP-ALL as an intermediate risk outcomes and may not warrant stem cell transplant upfront if the patient has undergone remission at the end of phase 2. Uh, Compared with children's, adult patients with ETP-ALL has similar results with corticosteroid resistance, persistent MRD positivity, and high rates of induction failures. So in this study, this has actually included the TALL patients and the patients who had corticosteroid resistance, high rates of MRD at the end of induction, and lack of complete remission patients as underwent allogenic stem cell transplant. Upon subgroup analysis, they identified that majority of these patients belongs to ETP-ALL group, and this is then outcomes when the patients are censored at the time of allogenic stem cell transplant. Patients with ETP-ALL has inferior outcomes compared with non-ETP-ALL. However, this difference is negotiated by the use of allogenic stem cell transplant. For the patient who received allogenic stem cell transplant, has an better outcomes compared with patients who didn't receive allogenic stem cell transplant in adult patients with ETP-ALL. Coming to the role of transplant in newly diagnosed T-cell acute lymphoblastic leukemia, these we can go through based on the either high risk, conventional high risk features based on MRD, based on genetics, and based on the ETP-ALL. Coming to the high risk features, this is then studies showing superiority of allogenic stem cell transplant in children with high risk features. The high risk features in this study are TALL patients who had poor prednisolone response and who had lack of remission at the end of induction. In these patients, patient who received stem cell transplant compared with conventional chemotherapy has in better disease-free survival. And this is the other study which showed then better outcomes with stem cell transplant rather than continue with conventional chemotherapy. In these patients, the high risk features in this study include TLL with poor prednisolone response and TLL patients who had a baseline white cell count of more than 1 lakh, or either of the high risk features or both of the high risk features. Coming to the other risk factor, lack of induction, complete remission at the end of induction. This is the study published in NEJM. where patients who had induction failure received allogenic stem cell transplant compared with conventional chemotherapy. As we have seen in this graph, patients who received allogenic stem cell transplant has better outcomes compared with continuing with conventional chemotherapy. And in the subgroup analysis, they suggested that T-cell acute lymphoblastic leukemias has better outcomes with allogenic stem cell transplant compared with chemotherapy. And coming to the minimal residual disease, minimal residual disease is identifies the disease which is not recognized by the conventional cytomorphology, and in both in pediatric and adult settings, presence of MRD has been associated with inferior outcomes. As we seen in these graphs, in adult patients, presence of MRD at the time point of week 10 has inferior outcomes compared with absence of MRD. And the kinetics of minimal MRD in TLL is different from BLL. TLL has late MRD responses compared with BLL, who attain majority of patients attain MRD negativity at the end of phase 1. Coming to the MRD detection methods, when can you see that real-time RT-PCR, which identifies clone-specific rearrangements in T-cell receptor gene, or other methodologies, flow cytometry, which uses leukemia-associated abnormal immunophenotype present at the time of diagnosis. RT-PCR has a higher sensitivity in the range of 10 power minus 4 compared with flow cytometry, which has low sensitivity in the range of 10 power minus 3. And RT-PCR is well standardized, and flow cytometry compared with RT-PCR is less standardized. Coming to the outcomes with the MRD, this is a study of BFM done in childhood TALL group. Patient has randomized into standard risk, intermediate, and high risk. High risk patients are the patient who had MRD positivity at day 78, and other patients as standard risk are patients who had MRD negativity both at day 33 and day 78, and intermediate as who has MRD positivity at day 33 but MRD negative at day 78. So this is the outcomes based on the based on MRD. One can see the patients who had MRD positivity in TLL at day 78 as inferior outcomes compared with who had MRD negativity at day 78. This suggests that the clearance of leukemic blast is slower in T-cell acute lymphoblastic leukemias, and MRD detection at later time point, that is day 78, is more suited to define risk of relapse in TALL. Uh, and high levels of MRD at day 78 has increased not only of medullary relapse but also increased risk of extramedullary relapses. As shown in this figure, patient who had MRD at day 78 has increased risk of relapses compared with MRD negativity at day 78. So based on this, in children with acute T-cell lymphoblastic leukemia, patient who has MRD positivity at two subsequent points, that is at the end of phase 2, has associated with high risk of relapses if treated with intensive chemotherapy alone. For these patients, allogenic stem cell transplant is recommended. And patients who had MRD positivity before transplant is also associated with increased risk of relapse, and additional treatment is required to induce MRD negativity before proceeding for transplant. Coming to the adult TALL studies, patient who has high risk features as mentioned here, who had age more than 35 years, white cell count at presentation more than 1 lakh, and presence of residual bone marrow disease at day 15, and present of baseline CNS involvement and high risk cytogenetics and lack of CR as inferior outcomes with continue if the patient has continued with conventional chemotherapy with 5-year overall survival ranging from 20 to 30%. So for these patients, allogenic stem cell transplant is recommended. And this is the previous conventional these are the conventional risk factors which has done before the use of MRD. With the use of MRD, patients who had persistence of MRD at phase 2, which is classified as molecular failure, compared with negative MRD, which is classified as molecular complete responders. Patient who had molecular failures has an overall survival of 26%, compared with molecular responders who had overall survival of 69%. This suggests patients who had MRD positivity at the end of phase 2 should undergo allogeneic stem cell transplant. Coming to the genomic risk factors, in this ECOG study, they had identified the high risk genomic risk factors which are associated with inferior outcomes. One can see the patients who had wild type notch and Fbx W7 has inferior outcomes compared with presence of these mutations. And other risk factors, presence of DNMT3A mutations. Patients who has DNMT3A mutations has inferior outcomes compared with wild type DNMT3A mutations. Other risk factors associated with inferior outcomes are IDH1 wild type and BCL2 deletions, BCL11B deletions. So, and uh, the additional risk factors which are accounted for inferior outcomes are, as we had already seen that Notch 1 wild type and FBX W7 as wild type as inferior outcomes. The patients who has uh, RAS and P10 mutations, these mutations are predominantly present in myeloid malignancies compared with lymphoid malignancies. Patients who has these mutations has increased incidence of relapse compared with patients who doesn't have RAS and P10 mutations. So these are the other subgroups who needs allogeneic stem cell transplant uh, in T cell acute lymphoblastic leukemias. So to summarize, the patients who had post-induction, I mean at the end of phase 2, who had MRD levels of more than 10 power minus 5 and unfavorable cytogenetics as we had seen before, that is wild type Notch and Fbx W7, and for the other patients are the presence of RAS and P10 mutations as increased risk of relapse and shorter relapse-free survival and overall survival. And these patients need transplantation. And other studies from GRAL study where they used MRD-based and genetic-based risk stratification tools compared with conventional risk factors like age, presence of high TLC count at baseline, and these patients are treated with pediatric-inspired protocols. For these patients, MRD has overridden the conventional risk factors like age more than 35 years, presence of CNS involvement at baseline, and presence of high white cell count at baseline. So, what has progressed in TALL? One is in adults with TALL, uh, presence addition of allogenic stem cell transplant uh, has better outcomes in ETPLL compared with continuing conventional chemotherapy. And for the patients who had Notch WX1 mutations, patients who had RAS and P10 alterations as inferior outcomes, and these patients, even if they undergo allogenic stem cell transplant, has inferior outcomes. So, based on this, the recommendations for allogenic stem cell transplant in first remission include patients who had failure to achieve complete remission at the end of induction, patients who had MRD positivity of more than 10 power minus 4 after 2 courses of induction therapy, patients who present with white cells of more than 1 lakh, complex cytogenetics, I mean presence of more than 5 chromosomal abnormalities, early T cell precursor acute lymphoblastic leukemias, and unfavorable cytogenetics like presence of P10 and RAS alterations and wild type Notch and FBX7 mutations. However, the conventional risk factor of presence of high WBC cells has been overridden by MRD negativity. For patient this conventional high risk features, if the patient has MRD negativity at the end of phase 2 induction, we can avoid allogenic stem cell transplantation. So to summarize, the patient is newly diagnosed TALL. The patient is fit for pediatric intensive chemotherapy. We use pediatric intensive multi-agent chemotherapy, and the patient has lack of CR at the end of induction. Patient needs salvage chemotherapy or clinical trial or nelarabine. And if the patient attained CR and MRD negativity, they go for allogenic stem cell transplant. And for the patient who attained CR and MRD negativity without adverse cytogenetics as we have seen wild type Notch and Fbx7 and presence of KRAS and PTEN mutation, they need allogenic stem cell transplant. For the patients who had MRD positive at phase 2 and adverse cytogenetics needs allogenic stem cell transplant. Uh, for the patients who are not fit for pediatric intensive chemotherapy, one can use conventional multi-agent chemotherapies. Similar to this, the patient has induction failure, they go for salvage therapy and transplant. And patients who had MRD positive and adverse cytogenetic needs allogenic stem cell transplant. Coming to the advances in TALL, one is incorporation of nelarabine. Incorporation of nelarabine in children has been shown in improved outcomes in ALL 0434 study. However, in adults, as we have seen previously, addition of nelarabine in upfront doesn't show any improvement. However, one can use nelarabine in the patients who had induction failure and persistent MRD positivity to get into MRD negativity and proceed with allogenic stem cell transplant. Other advances in TALL is use of venetoclax. There is a phase 1 study which showed that patient who has heavily treated with B and TALL has response rate of 50%, and this can be used as an target to attain MRD negativity in patients with MRD positivity. And other advances are upcoming advances are CD5 and CD7 card. These trials has been initiated. The results are yet to come. And other is T and precursor TLS and has an expression of CD38. And daratumumab can be used as a drug to attain MRD negativity for patient who has persistent MRD positivity to proceed to allogenic stem cell transplant. Thank you.
Thank you, Vasu. That was a comprehensive presentation. So I think there are a couple of questions that Madam has already answered that. So Alok has asked, what is the role of molecular analysis beyond prognostication in the TALL? That he's specifically asking probably about Notch mutations and RAS mutations.
Prognostication wise, as we had already seen, the patients who had wild type Notch and Fbx7 has poor outcomes compared with presence of Notch. And other is even who had Notch mutation, presence of PTEN mutations and KRAS has poor outcomes. This suggests, I think, this belongs to ETP-ALL because these are these are the mutations which are frequently present in myeloid malignancies compared with lymphoid malignancies.
Yeah, just to add to that, Vasu, that the GRAL group has already, I think, in the multivariate analysis have shown there's no. So when you say that prognostic and predictability, whether we should do a transplant for a Notch1 mutation or a RAS PTEN mutation, even if they attain MRD negativity, probably no, because after the GRAL combined analysis, that probably it is the MRD that scores out every baseline prognostic factor. So as of now, for Alok, there is no predictive capability, but it's only prognostication.